Good afternoon, everyone, and welcome to the March 2022 Population Health Collaborative meeting. We are experiencing some technical difficulties today, so we appreciate your patience. If we lose anybody at any time, presenters or you all, we just ask that you go ahead and rejoin us as soon as you can. I am Suzanne Lawson with Constellation Consulting, and we are the convener for the collaborative. The Population Health Collaborative is funded by the New Mexico Department of Health Heart Disease and Stroke Prevention Program, and today's presentation will be focused on team-based care. Please note that this meeting is being recorded. Attendees' cameras and microphones are activated today. However, we do ask that you keep your microphones muted. Following today's presentation, we will have time for Q&A, and you may ask your questions live or post your questions in the chat window. Also, if you would like to make sure that you're added to the collaborative email list, please enter your email in the chat window, or you can email me directly at suzanne@constellationnm.com. And there's my email. Today, we are pleased to have Lindsay Hawkinson, Program Manager for the New Mexico Department of Health Heart Disease and Stroke Prevention Program. Lindsay will discuss best practices in team-based care and team-based care models. Please welcome Lindsay Hawkinson.
Well, hello, everybody. Thank you for that lovely introduction. So yes, I'm going to discuss team-based care. So as a part of the 1815 collaborative or cooperative agreement with the CDC, they have tasked states with specific strategies for preventing heart disease and stroke. So one of those strategies is to support the engagement of non-physician team members in hypertension and cholesterol management in clinical settings. So team-based care. This, of course, looks very different in each unique organization, but I do want to go over broadly what team-based care looks like, some of the evidence of its effectiveness in the prevention of heart disease and stroke, core principles of team-based care, and some steps for implementing team-based care. So next slide, please. All right, so what is team-based care? So team-based care is a strategy that can be implemented at the health system level to enhance patient care by having 2 or more healthcare providers working collaboratively with each patient. Within this context of cardiovascular disease prevention, it often involves a multidisciplinary team working in collaboration to educate patients. They will identify risk factors for disease, prescribe and modify treatments, and maintain an ongoing dialogue with the patients about their health and their care. These teams may be made up of doctors, nurses, pharmacists, community paramedics, primary care providers, community health workers, and many others, which could include dietitians or other members of the community. So next slide, please. So as we move on to the effectiveness of team-based care, these most recent recommendations and numbers are coming from the Community Preventive Services Task Force. And this is based on evidence from a review of 54 studies from a search period from about January of 2012 through June of 2020. So evidence of these studies have shown that interventions led to improvement in blood pressure outcomes. Studies have also shown an improvement in total cholesterol as well as LDL. As you can see here, there was a median increase of 8.5% in the improvement of the proportion of patients with controlled blood pressure. There was also a lowered systolic, blood pressure of 3.5 and diastolic by 2.1. Additionally, there was a median decrease of 3.8, which was seen in total cholesterol, and a decrease of 3.9 in LDL. Oh, that's the next slide I need. Oh, next slide, please. There we go. So this has also had an impact on health disparity. Findings have shown a strong evidence of effectiveness for team-based care organized primarily with nurses and pharmacists while working in collaboration with primary care providers, patients, and other professionals. Evidence showed meaningful improvements in blood pressure control for Black or African American patients and Hispanic or Latino patients. When this is implemented by healthcare providers to serve patients from racial and ethnic minority groups, interventions are highly likely to advance health equity. Additionally, evidence has shown that these interventions are effective among low-income populations and patients with multiple health conditions. As far as an economic impact, the median cost per quality adjusted life year gained is approximately $24,000, which is well below the conservative threshold of $50,000. Additionally, I have provided in the resources a link to a calculator from the AMA that shows cost savings from team-based care so that you are individually able to go in there and see what the impact would be on your individual organizations. Next slide, please. All right, so some of the outcomes from team-based care are that they will facilitate communication and coordination of care support. They enhance the use of evidence-based guidelines. They'll establish regular structured follow-up mechanisms to monitor patients' progress and scheduled visits. And additionally, they actively engage patients by providing them with education, adherence support, and tools and resources that are needed for self-management. Next slide. All right, now we're going to kind of get into some of the meat of this. So the core principles for team-based care were compiled by Bell and Health, and they may be very helpful when preparing to adopt a team-based care model. So of course, number one, as always, patient first. Providing comprehensive, high-quality team-based care to patients and the community will help to create a healthier community and overall patient population. Next, a team culture. A team culture is vital to the success of an organization and of course to a team-based care model. So a team is an organized entity that together accomplishes more than can be accomplished individually. This mindset must be ingrained in all team members to allow for the provision of the very best care. Empowered staff. All team members should work at the top of their skill set and they should be proactive in finding ways to help care for patients. This develops trust between team members and it enhances a work-life satisfaction for each of these team members as they do realize that they have a critical and key role that they play in providing this patient's care. So this also is going to encourage critical thinking. Each member of the patient care team is as vitally important as the next, and all team members should be continually looking for ways to anticipate the needs of both the patients as well as the other team members. Therefore, they're able to proactively meet those needs. This strives for the highest patient quality care and increases effective team dynamics. And lastly, knowing your population. This is going to consist of analyzing the composition and the risk profile of a practice population. This determines the anticipation of resources required for high quality and comprehensive patient care, and allows for the development and improvement of measures to ensure that the care is delivered in as effective way as possible. So, next slide. Alrighty, ooh, that loaded different. Well, this is the 5 steps for creating a team-based care model and for implementing it into your organization. So, step 1, create a change team. So this team, this is who's tasked with creating the model, creating the workflows. So this needs to be a multidisciplinary team, needs to include nurses, MAs, physicians, of course, hospital administrators, members of the IT team, CHWS, etc. And there needs to be a physician leader who has the authority within each organization to empower this process. There needs to be that person high enough up that can make it happen and bring the change about. So, as I said, this team is tasked with designing the team-based care model, and they're going to work to make a model that best serves the patients as well as the team members within the organization. Step 2, design a team-based care workflow to fit your goals. So this is an exciting chance. This is the opportunity to evaluate what has been working and where there are opportunities for improvement within your own organization. You can incorporate those processes that do work into the model and change and make adjustments where there is opportunity for more efficacy as well as just more efficiency within your team. So there are some fundamentals to team-based care that really make it work. And this is going to come along when you're making these workflows. Of course, number 1 is pre-visit planning. This ensures that patients and team members are prepared for visits, and this is a cornerstone of a team-based care. Next is expanded rooming and discharge. So this involves a member of the team initiating and closing out each patient visit. So these include things like assembly of necessary equipment for the visit in that room, so it's there and ready and the patient's not waiting while those things are brought together. Updating of records, ensuring that lab results are in and ready to be accessed. Reconciliation of meds, talking to that patient about what's on the record versus what they're actually taking at home. An arrangement of proactive and preventive services. If there's something that patient would benefit from, schedule that appointment then. Connect them with those services in the moment. Additionally, there will be the follow-up after that appointment, which will allow those patients to be connected with any referrals that are made so that that loop is closed in the time. Of course, next step with this is team documentation. So a clinical team member or a trained documentation specialist will actually remain in the room with the physician during the visit, and they will scribe the visit. This allows the physician to have more face-to-face time with the patient as opposed to talking to their patient while typing their notes on focusing on a screen, and allows for that scribe to do follow-up in the moment. They can arrange for any care coordination services on the fly. Of course, medication management. It's highly recommended to get patients on an annual medication synchronization program. All of those regular medications that those patients are on, if they're able to have those prescribed and starting at the same time of year, they can get those refills and renewals in that one visit, and they can make the most of their visit to your clinic. And lastly, EHR management. In a team-based care model, the number of in-basket messages sent to a physician should decrease, and it should decrease fairly dramatically. And this is largely because, number one, lab results. They're discussed during the visit. Patients receive additional education at the conclusion of their visit. There's not those follow-up questions. They get home, they read the discharge instructions, and they don't understand, and they come back with questions, or they don't ask the questions. Care coordination is enhanced. There's somebody in the room during the visit. A CHW, whoever it is, knows what's going on, and they're able to help coordinate those after appointment visits. And those referrals can be made during the visit. So once you've got your workflow, you're going to select your pilot team. And this pilot team is very important. It's going to be a small team. They're going to pilot the model. But the members of this team, they should be the trailblazers, and they should be good communicators, and they should be so willing to put in the extra effort and to prepare for the transition and continue developing the model as it's going through and once it's underway to ensure that it's best as possible. So next, you're going to implement these workflows. And there's some steps that need to happen with that. Communication is key. Anytime there's change like this, communication is key. Number one, the team needs to be prepped. Inform them that team-based care implementation is a gradual process. This doesn't happen overnight. Change is not easy, and it takes time, and not every day is going to be perfect, but we learn from the bad days and we move forward. Communicate this to the patients. Patients need to know how their visits are going to change, that there's going to be different expectations, and that there may be more people in the room, but that doesn't mean that their privacy is going to be breached or anything is going to be wrong. It's all to better their visit and their time with their provider. And lastly, keep the rest of the practice in the loop. They need to know how this pilot is progressing and that anything implemented is not going to negatively affect their work and their day. And lastly, as this pilot is going through, you want to track these outcomes and you want to optimize your process. The model will need to evolve and grow along with the needs of your organization and your patients. Evaluate your processes, celebrate your successes, and build upon those successes. Next slide, please. So I'll have shared out, I'll have Susanna and Bianca email out these slides and this resource very specifically. I've shared some resources that came through from the CDC. They're not CDC websites, but they're shared by the CDC that they for implementing, as well as just resources about team-based care and best practices within it. And next slide. Lastly, I've included my contact information as well as information for the Heart Disease and Stroke Prevention Program. So if there's any questions that you have for me, please do feel free to reach out either by email or my phone number. And I'm also available for any other follow-up or questions that you have related to heart disease and stroke prevention here in the state. So thank you very much.
Okay, thanks so much, Lindsay. We will have time for Q&A at the end of today's session. So if you have any questions that you want to make sure we address, go ahead and put them in the chat and we will make sure that we circle back to them at the end. So now we are pleased to have Bianca Kurtzen, who Bianca is actually also part of the Constellation team. She actually facilitated the last PHC session. But in her regular life, she's also the population health manager at La Clínica de Familia in Las Cruces. And so we wanted to invite Bianca here to discuss implementation of team-based care in chronic care management. So please welcome Bianca.
Thank you, Suzanne. All right, so I don't see my slides. Are they on your end? All right, perfect. Thank you. Thanks, everybody. So yes, I am the population manager for an FQHC here in Las Cruces, New Mexico. And so I'll be sharing our, as Lindsay said, celebrating our successes and sharing our challenges as we implemented this new team-based program that we call chronic care management. Next slide, please. So as I mentioned, La Clínica de Familia, we've been around since 1978. We're pretty established in this community, especially in Doñana County. We are a private non-for-profit federally qualified health center. And so within our organization, we offer medical services, behavioral health services. We have a women's clinic that also provides OBGYN services. We deliver babies, dental, and we also have pediatrics. And I'm probably forgetting a few others. We also are located in 6 high schools with our school-based health centers as well. So we have over 40,000 plus patients just within our network of services. So we're a pretty large organization and serve a pretty large population. Most of our services are not only funded by grants or contracts, but we're also fee for service like a regular primary care provider might be. And so we just have different streams of revenue funding that way. Next slide. So a little bit about chronic care management. I had not heard of chronic care management upon starting this position. The role was to, start with CCM, is what we call it, chronic care management. Start with CCM and then branch out to other types of population health initiatives. And so CCM is actually a CMS program that is really targeted to help our Medicare patients, so our 65 and older, our elderly patients with their chronic illnesses. And so I did include a list of chronic illnesses that we see the most, but they're not limited to these. We also have other diagnoses, behavioral health diagnoses, anxiety, depression, that could also be included in this list. But it's really identifying who these patients are. If they have 2 or more chronic conditions, they have a Medicare plan. If they have Medicare, Medicaid, it's part of their health insurance coverage, so there's no copay. Historically, there was a copay associated with this, but as CCM has grown, CMS has gotten a little bit lenient. During COVID, they developed waivers for copays. But for the most part, if a patient has either Medicare, Medicaid, or a Medicare Advantage plan, there are no cost sharing or copays for this type of program. And so next slide. So a little bit about what CCM does and what the goals are. So chronic care management does implement team-based care. We assign these patients a nurse that calls them about for 20 minutes every month. We ask the patients if they want to, we let them know that they qualify. We do a lot of outbound phone campaigns that they qualify for this program. We explain how it benefits their care. I'll be explaining everything that we could assist with. Once the patients consent to be in the program, they get a care plan by one of our nurses. So we have some LPNs on our team. We have MAs and CHWs. So we initially start with the care plan, and really with the goal of improving patient outcomes, just being more engaged with the patient outside of that clinic visit. So it's really also coordinating care with pharmacy, with specialists, being able to relay back messages to our providers in-house, doing warm handoffs to dental, to pediatrics, women's, whatever the case might be. So doing those warm handoffs internally and being able to make those, closing that loop with referrals externally. So it increases patient engagement. We've seen that it has reduced ER visits as patients are calling us in directly, asking, should I go to the ER? I have this. Being able to get them in the same day has been very beneficial. Reducing hospitalizations as well. We also want to centralize management of patient needs. We want one place where a patient can call and we're able to do that warm handoff or be able to help them in that one call. We don't want them to be transferred here and there and they just kind of get lost in all the noise. Improve communication and care coordination. So really being able to be that one person that our team could assist that patient with whatever needs they might have. Closing gaps in care, working with our insurance payers and MCOs on closing HEDIS gaps, whether it be diabetes care measures, hypertension, med adherence is a huge one. Really working with our payers because they have these claims data that are really beneficial that can dictate who's at high risk, who are patients that we should be targeting. And that's really where we started when we started outreaching to these patients was being able to say, who's our high ED user, who's, really high on med or really low on the med adherence, like who could we help the most? And that's where we started, and really being able to drive that. And CCM also serves as a foundation for other programs. So there's so many other programs that we could branch off of this, particularly for our Medicare population and our Medicaid population. Next slide. So just a little bit about our CCM population. We have about 7,000 eligible chronic care patients right at today. Right now, obviously our capacity was we wanted to really build the program and do it right and work out all those kinks and do those workflows and really build up the program. So currently we have about 800 patients enrolled right now. Our nurses are calling them every month. We're checking in. We're still enrolling, but we potentially have 7,000 patients to enroll. And so we do want this program to grow. So the sky's the limit with this program as long as we have the capacity. So a little bit about what services that CCM provides. And so I know Lindsay mentioned kind of like that whole care team, right? It's the physician, it's the pharmacist, it's the social worker, it's the CHW, it's everybody. It can be community resources. It can be everybody. So a little bit about the care plan. So the patients are required to have a care plan done by one of our nurses. And so it's something that happens initially once they enroll. It is a personalized health care plan with all of their health conditions. It has goals, interventions, and objectives for the patient. So whether it be diabetes, hypertension, whether it, depending on what their diagnosis is, we work on goals with each individual patient. Once they sign up for the program. There is a lot of care coordination between the doctor, the pharmacy, the specialists, labs, testing, imaging centers, hospitals, personal care service agencies, food banks. My nurses and MAs are able to call and really help coordinate and close these loop on a lot of these services that can't happen at the clinic level just because clinics are busy seeing the patients face to face, whereas we're able to take the time outside of that clinic visit and complete all these services for these patients. Because we're a federally qualified health center, we're only able to bill for 20 minutes of this time. So I failed to mention that this is a reimbursable service. And so CMS reimburses us for this CCM service. If you're a private practice or you have your own primary care group, you're able to bill up to 60 minutes, I believe, but because we're federally qualified, we're limited to the 20 minutes. And so our nurses call these patients every month for up to 20 minutes. Sometimes it takes longer depending on the patient's need. We understand that we're not getting paid for that minutes, but it really helps gain the trust with the patient and really build that rapport. But every month we have that opportunity to bill for that 20 minutes. We're also able to provide assistance with community resources and needs. And really working with that social determinants of health model and identifying what types of housing the patients, what their background, what their education is when we talk about health literacy and med adherence and how it all comes together. And so we're currently doing that as well. And managing medications, med adherence is a huge one. So just even that reminding and prompting to patients, hey, your medication refill is coming up due now in April. Do you have transportation to get to the pharmacy? Do you want us to sign you up for mail order pharmacy? Try to eliminate all those barriers that come with med adherence issues with patients. And we also provide expert assistance with setting and meeting their health goals. Our team is made up of LPNs and MAs, and so they understand, they're able to do triage, and they're able to do ER precautions over the phone, behavioral health crisis management over the phone, and so they're very skilled in that area as well. Next slide, please. So a little bit about our team, and so I know Lindsay mentioned starting somewhere. Where do we start? And so it really started with the idea. My director of nursing and our CEO and CFO said, we want to start doing CCM. We think it's the right thing to do. We're able to build revenue from it as well. And it's the right thing to do for these patients, especially our chronic care patients. So the idea started with leadership. I was brought on as to kind of start the program from scratch. And so I was able to hire my team, build the workflows, change things as we went. We're still, we started October 11th. And so from October 11th to now, we've managed to enroll 800 patients and actively been able to support them in whatever they need through the holidays. Med adherence was huge during the holidays because pharmacies were closed. And so being able to assist those patients during those times was we were able to see the need for that. We also have our LPNs. So I have 3 LPNs on my team who assist with development of the care plans. Once the care plans are completed, any of my MAs, my 3 MAs can do time for these patients. So we will outreach to them, check on them. We review the chart. We review old past provider notes. We follow and circle back with referrals. And so we are able to do all that to kind of prep kind of our pre-visit, our pre-call planning before we outreach to the patient and be able to assist them. We also just added a community health worker to our team. She was an internal transfer. She is very well versed in our community and has been a great asset to the team because we're able to assist these patients in real time with services that are oftentimes urgent or in a very timely manner. And really all clinical staff play a role. And so when we roll this out, we presented it to our providers. This is the chronic care management program. Send over your referrals. And so not only are we doing these cold calls to patients, our high-risk patients, if a provider has a patient that feels that he can benefit from the program, we get the referral from the provider. Everything lives in our electronic health record. So we can do our timer for our time in the electronic health record. We document in our electronic health record. Everything is in there. And so everybody can see what we're doing. Everybody knows what is going on with that patient. So really all clinical staff from our call center all the way up to our providers can really see the benefit of this program. Next slide. So I know I was here to talk about a little bit about team-based care, but this is really just a good illustration of what it looks like. It involves our care team for our provider, our nurses, our CHWs, our MAs. We're not doing home visits right now, but that was always an expectation. If a provider said, I really want to know what this patient environment is, I want to know what their refrigerator, what's in their refrigerator, what they're eating because their levels are so high or whatever the case might be. We do have the capacity to do that. And so being able to follow up with referrals, clinic referrals, community referrals, our care plan, our monthly review with the patient, we follow up with the PCP because they're our doctors, they're in-house. And so we're able to either pick up the phone or do a quick Teams message to the provider about a patient. And it makes it just so much easier and it's fast, it's timely, rather than the patient having to wait, call into the call center. We have our direct line for our particular program, which is another benefit that we tell patients. If you sign up, you have a direct line to our nurses anytime, Monday through Friday, 8 to 5. But, we do have after hours in the event that there's something that needs to be done after hours. We have our doctor on call. If the provider looks at the patient, he's going to see, oh, yep, they're enrolled in the chronic care program. Let's see what we can do to support them and get them through the weekend. And so it's really a team effort. Our providers have to co-sign every single care plan. And we've had over 700 care plans be co-signed by our 30 plus providers. So it's really been a company-wide, organization-wide effort to get these patients assistance. Like I said, during the holidays, we got patients, we were delivering food boxes to patients who said, we don't have any food for Thanksgiving or for Christmas. Being able to help a patient with a heater repair. We worked with a local agency to get his heater repaired. Working with the governor's office for the ramps and shower bars for people and rails that don't qualify for their Medicaid because they don't have Medicaid. So we're trying to get them other resources. So it's really been a team effort to support these patients. Next slide. So as I mentioned a little bit about social determinants of health and how important it is, we could work on med adherence and we could encourage them to check their blood pressure and to take their medication, but there's so many other factors that come into play. And that's really what I've drilled into my nurses and my team, is that we need to get down to the root issues and the root causes of why these patients aren't adherent or why they're continuing to be in and out of the ER. What's going on? And so we do a form it's in our EMR. It's called a prepare form. It's through the Nationally Community Health Center Foundation, I believe is the organization, but it's prepare, PREPARA. And it goes into questions regarding their housing, their education level, what other resources do you need? Do you feel safe in your home? Being able to connect patients to behavioral health if they're having any type of anxiety, depression, because we have all that in-house, it makes it that much easier, right? So, but until we know and paint that picture, and patients don't always outright say it or come out and say it. But by asking this questionnaire does a really good job, especially after they've already gained our trust. We've been calling them for a couple of months. They're able to open up and, we ask these questions in a way where they don't feel threatened or it's intrusive. And we're able to really, really help these patients, not only on a medical level, but also on a more social determinant of health level. So that's been my favorite part, is to read the notes and hear the calls of these patients. And, patients are now calling us. I think I need a refill. Can you double check? I need an appointment. I'm not feeling well. Oh, I think I hit my head. I'm worried I have a concussion. I need to see my doctor. Can I see her today? So making those same day appointments and preventing those, unnecessary ER visits and time and stress on the patient has been really wonderful to see as well. A couple other things that I wanted to share before I end, we want to really also start working with other of our community partners. So working with the Department of Health and with Synchronous on our controlling blood pressure. So we just started a pilot program for our particular chronic care population, and we're going to start tracking home monitoring, and to kind of see, if they're journaling and taking it back into the provider's office to see if there's a difference on controlling blood pressure, because we do know that that's something that we really want to try to assist with, and being able to track that data, and to also see our progression, to see if we've made progress, right? Because ultimately we want to be making things better. We want to be able to track our success, and so working with these types of organizations to be able to track our success and being able to share our experiences is also our next step. So thank you so much. That's all I have for today. And if you ever have questions on CCM, if you need help getting started, this could be overwhelming, I believe, for a small practice, but we were able to do it, and there's a lot of resources online, and I'm happy to help anybody who has any questions. Thank you.
Thanks, Bianca. There have been two comments. So first of all, Lindsay Sarah says, great job. And for you, Bianca, Lindsay over at Workshop Wizard said she applauds the inclusion of community referrals and community events. So fantastic.
Thank you.
Okay. And so now for our closing presentation, we are pleased to welcome back Jamie Slama. Jamie is the statewide training certification coordinator for the New Mexico Department of Health, Office of Community Health Workers. She has been with the Department of Health for 8 years, and before working for the state, she was a nationally certified medical assistant with ABQ Health Partners. Please welcome Jamie.
Hi, everybody. You can go ahead and skip that slide.
Okay.
So we always start off with our mission from DOH. So these are just our mission. Obviously, it's to ensure health equity across New Mexico. We have it, and the way to reach health equity here at DOH, we believe, are through our 4 goals. So all of our slides start off this way, guys. This is just a generic, but go ahead and switch slides for me. Same with our values for DOH. Health equity is our priority, just so you guys know. And then we go down with accountability, communication, teamwork, respect, leadership, and customer service. Next slide, please. So I'm here to talk about how CHWs can be incorporated into care teams. The first thing is CHWs are a long-standing yet emerging workforce. And what I mean by that is community health workers have been around for decades. However, recently, we've taken an a nationally recognized effort about what community health workers are about and how effective they've been. So recently, in the last 2 years during COVID, CHWs across the nation have been recognized and are starting to be utilized for some of this COVID work. And because of that, it's making them a more known profession. So I'll have you go ahead and skip that to the next slide. However, community health worker is the broad term. And so you can see there's several terms that community health workers fall under. And believe me, there's over 100. And I think the last time I searched, it was almost just below 200 titles that community health workers fall under here in New Mexico alone. Those are just the top titles that community health workers can have as a title under different social service and different clinics and different roles that they may play here in New Mexico. Next slide, please. So first I want to tell you a little bit about our office. So the Office of Community Health Workers, who do we serve? We serve CHWs, community health workers, and that are not certified, and we assist certified community health workers here in New Mexico that serve in rural, frontier, and underserved populations. And we make that very clear. So we have CHWs that work in the rural frontier communities as well as underserved populations here in New Mexico, meaning there can be somebody here in Albuquerque that is underserved. So we want to make that very known that CHWs work across New Mexico. We have partners, again, certified and non-certified CHWs, community health representatives, state agencies, learning centers, community-based organizations, clinics and providers, academic institutions, CHW and CHR programs and associations across the nation. And we are 100% general funded. Next slide, please. Why are CHWs important for New Mexico? New Mexico ranks at or near bottom of many national health statistics. So we believe CHWs play a vital assist in helping with these vital characteristics. Population is one of the most diverse in the nation. So because we are rural and frontier, we believe that CHWs assist with reaching out into these communities that don't have healthcare facilities. We have critical shortage of primary oral mental health care providers, particularly in rural and inner city areas. More than 1/3 of our population lives in frontier areas, including tribal areas. We have poverty level above the national average and health disparities among racial and ethnic groups. So again, we believe CHWs help reach the populations that are unreachable. So go ahead and next slide. CHWs are uniquely equipped. First thing you can see, our bold thing is a matter of trust. Community health workers are able to build the trust within their communities, which is amazing when it comes to the reach that they are able to do. For instance, we say that they reside in their communities that they serve. So most CHWs, they do serve out of their areas, but particularly we try to have CHWs serve in their same areas. They speak the same language. They come from the same ethnic, cultural background. In some cases, educational background as well. They link individuals and families to social and health systems of care. They advocate for services to meet community needs, which I mean by that is they go out into their communities and they attend community meetings. They rally for their communities. If they don't have something, they go out there and start these meetings, especially when it comes to local and state government. They provide culturally responsive, cost-effective health information. So they act as a translator in most cases. They attend patients' appointments with them, and they are the translator of health information. So when it's at a higher level, we say they dumb it down, but really it's just that they are able to communicate what's being said during all that medical terminology, they break it down into layman's terms so that the patients can understand what's being told to them. They teach and support families to learn knowledge skills needed to manage, treatment, and prevent disease. Community health workers are really good about teaching patients to be self-sufficient. So they teach them, they work with them, and they support them. And then they empower individuals and communities to advocate for their own health. Again, they hold a lot of community outreach activities, and through that they advocate and teach others in their communities to advocate for themselves. Next slide, please. New Mexico CHWS. We have approximately around 900 CHWs in New Mexico. That is not all certified. We are a volunteer state where you can volunteer to be certified or non-certified, but our total is around 900 CHWs in New Mexico. That is not including, we are the one of the few states that have CHWs that live in Arizona and also live in Texas, but they are certified in New Mexico because they do work here. They serve all racial and ethnic groups. They're located in urban, rural, tribal, and frontier settings. Again, they assist with language interpretation. Historical focal areas where they were originated was through diabetes, heart disease and stroke prevention, obesity and chronic disease management, and maternal and child health. Majority of our CHWs are female. However, we are increasingly every single day, we're getting more men interested in the workforce. So we do have a broad number of gentlemen as well. About 1/3 have at least some college experience. That again is also increasing now that some of the MCOs have wanted bachelor's degrees. So we do accept the community health degree programs at Dona Ana Community College as well as UNM as an entryway into being state certified here in New Mexico. As you can see, the wage that they usually are paid here in New Mexico are between $12 and $22, and that's our average here in New Mexico. Go ahead and next slide, please. What they do, CHWs help improve health status, critical role in increasing access to care. They help with reducing health disparities, coordinating comprehensive care. What that means is that if they go into a home and they do an assessment and they realize a patient, let's say they have asthma, and they see all these triggers, and when they go in to do their assessment, they actually write down all the issues that they identified in the home and then bring it back to the team and then express what needs to happen. So maybe a child has frequent ER visits and doesn't realize that they have several triggers in the home. The CHW will identify the triggers and report back. Research demonstrates that CHWs reduce healthcare costs, extend the reach again out into those rural frontier communities, and also not only extend the reach, but extend the quality of healthcare to individuals that may not have the opportunity to go to a healthcare facilities. The CHWs go out to their homes, do these blood pressure checks, fingers pricks, and diabetes, assist with that, and then also just go in and do well checks. They also improve individual health status. Again, like I said, they go out, they do home visits. Most community health workers in the South go out into the homes, and so would do the CHRs on the tribal lands. Next slide, please. As you can see, the CHW scope of practice and roles, they have many roles, and we broke it down by categories. So they have, we have community outreach categories, community and cultural liaison, system navigation and coordination and case management, home-based support, what they usually typically do when they're in the home, health promotion and health coaching, community assessment and mobilization, and clinical support. So they have many roles that fall under them. And depending on the area of expertise, whether they're in social service or a clinical setting, it depends on what role they'll take on with in their area and involved in the care team. Next slide. So we were approached by Heart Disease and Stroke Prevention on the CDC strategies and how we felt like CHWs can be incorporated into care teams. So the first strategy was to promote the adoption and use of electronic health records and health information technology to improve provider outcomes and patient health outcomes related to identification of individuals with undiagnosed hypertension and management of adults with hypertension. So right now, CHWs utilize the EHRs to assist with assessments and the documentation of their visits. CHRs actually input the data into the EHRs. And then strategy B3, support engagement of non-physician team members, nurses, nurse practitioners, pharmacists, nutrition, physical therapists, social workers in hypertension and cholesterol management in clinical settings. We say incorporate CHWs into the healthcare teams. So it's been very effective across New Mexico that now that clinics are getting onboarding of CHWs, they can see the effectiveness of how having a community health worker on the team to assist with referral process and resources, and also to do those home visits have been effective. And then strategy B4 is to promote the adoption of MTM between pharmacists and physicians for the purpose of managing high blood pressure, high blood cholesterol, and lifestyle modification. CHWs are the frontline healthcare providers who initiates the MTM process. Next slide, please. Heart disease and stroke prevention strategies continued. Strategy B5, develop a statewide infrastructure to promote sustainability for CHWs to promote management of hypertension and high blood cholesterol. OCHW has already partnered with heart disease and stroke prevention, and we're building and supporting an infrastructure to promote sustainability for CHWs. Heart disease and stroke prevention has created a specialty track that will be going live hopefully by June, and that's to train CHWs just in heart disease and stroke prevention. And then we also have a clinical support skills specialty track, and we want to train all CHWs on that as well, so that way they can go out into their communities and do blood pressure checks and teach patients how to read their blood pressures. Strategy B6, facilitate use of self-measured blood pressure monitoring with clinical support among adults with hypertension. Again, many CHWs are already trained in clinical support skills and are ready to go into communities and conduct home visits to demonstrate the effectiveness of blood pressure checks. And also OCHW will provide clinical support skills training on an ongoing basis. So we want to again ensure that every CHW has the opportunity to go through this specialty track, and that they have the skills needed to go out into their communities and into these homes to do blood pressure checks. And then the final strategy that we're involved with is implement systems to facilitate systematic referral in adult with hypertension and high blood cholesterol to community program and resources. CHWs are instrumental in processing referrals and educating patients on their health and promoting healthy lifestyles. CHWs conduct community engagement trainings to support HDSP strategies. So, and that is it.
Sorry, I did not mean to rush you there, Jamie.
No, you're okay.
Okay, so thanks so much, Jamie. We appreciate your insights. And so now we welcome any questions from our attendees and participants today. I do have, if you have a question, go ahead and put it in the chat. Go ahead and raise your hand on the reactions, and I will call on you. I did have one quick question kind of to get things started for Lindsay, and that is, can you talk a little bit about the technical assistance that DOH may be able to provide for a system, a clinic who may be wanting to focus more on team-based care or integrating CHWs into a team-based care model?
Sure. So number one, we do have some partners. I see several of them here who are very equipped to help with the EHR side of that model. Like Bianca mentioned, it's very, very vitally important that all of that information be able to be tracked within the EHR. And so we do have many partners that help with the data side. So number one, we have that. Additionally, I'm here as a resource to connect health systems with organizations that can help them to implement, to answer questions, as well as help as any kind of partner like that. I hope that kind of answers it. Like we're here to be any level of resource that we can be and connect with our partners, as well as working with OCHW. We can help to connect with CHWs. You know, Jamie is available to help connect CHWs with the work. And so that's some of the ways that we can be available to partner and help.
Great, thank you. Bianca, I did have a question for you. Can you talk about some of the biggest issues or some of the barriers that you've run into as you have been going through this team-based care implementation?
Yeah, so initially, when we would call patients and offer the program and explain all the benefits and what it entailed, and they were very apprehensive, where are you calling me from? So it was really important that we changed our script. So I think a lot of it was our scripting. So really changing it to, we're part of La Clinica, we work with your provider. So, and then using our med adherence reports from the payers was huge, because I can tell them, hey, you haven't picked up your lisinopril, what's going on? And so they knew like, oh, okay, they're calling from my doctor's office. So just really changing the script really helped. Challenges, we're a big organization. We have almost 40 just medical providers alone. And so getting everybody on board and letting everybody know who we are. There were times a patient would call the call center, and if they had a new staff that wasn't trained, they would say, we don't know what that is. We don't know who that is, because we have our own number, right? So all those kinks have been worked out since then, but that was early on. But just making sure everybody was on the same page. But when you're a pretty large organization, it can take time. So whether it's having separate meetings, I do a newsletter every month with like our organizational newsletter, reminding them, here we are, this is who our team is. So just being consistent with letting them know who the team is, what you're doing. And then as they start seeing your name in the EHR, they're going to start knowing what you're doing, but it will take time.
Great, thank you. And we did have one comment from Adam to Lindsay that their office, which is University of West Virginia, is glad to help provide the EHR data support. So thanks, Adam, for that. And then Jamie, I had a question for you. Can you talk a little bit about the training that is available to CHWs who are maybe new to team-based care, or new to that team-based care setting, and or any training that's available to clinical settings who are wanting to utilize CHWs more?
So the Office of Community Health Workers has a few trainings. The first one is core competency. So if a care team is interested in incorporating a CHW into their team, that they can send them to core competency training through either the state of New Mexico, which is 100% free. Our partner Presbyterian also is 100% free. There's other community colleges and programs that do have a fee, but we're the two that are free. We also have we just launched a training site with heart disease and stroke prevention that is on, they have the option to complete 11 hours of CEUs on chronic disease self-management courses. And then that will also be the area that's hosted, that's going to be hosting the heart disease and stroke prevention specialty track. But if anybody's interested in getting training to have CHWs on your care team, they could reach out to me personally, since I am the training coordinator, and I coordinate the opportunities of doing in-person training or virtual training for the regular core comps, just to get them ready to be incorporated into those care teams. That's what I would recommend. A lot of CHWs have the option to grandfather in here in New Mexico, But what we've realized is it's starting to fade out because they don't have that work experience prior to May 21st, 2014 here in New Mexico. So eventually that will be going away. We're working on our new rules and regs for that. So yeah, if anybody's interested in any type of training, whether it's specialty areas in particular, or just becoming a community health worker and how we can incorporate you guys into care teams, just reach out to me.
Fantastic. Thanks so much. And I don't see any more questions. So I will say thanks again to everyone for your attendance and participation today, and special thanks to Lindsay, Bianca, and Jamie for joining us as presenters today. And before you all go, if you'll complete the poll that has popped up on your screen, we'd greatly appreciate it. This poll is anonymous and it helps us in our QI efforts. As this group continues to move forward, please know that we will be posting information and updates to the collaborative website, which is at nmhealthequity.org/PHC. And more information will be coming soon about the Population Health Collaborative Conference later this year. And we do have one more meeting that will be coming up in May. So thanks so much, everyone, and have a great day.